happy to have you here. But yeah, well, it's 10:01. Some more people trickling on. We'll go ahead and get started. Yeah, it's my privilege and honor to introduce Dr. Samir Gupta. Dr. Gupta is a professor and gastroenterologist at University of California in San Diego, where he also works at the VA. Uh, he's really a senior surgeon or a senior scientist that's had a big impact in cancer control and prevention, specifically for colorectal cancer. And if you look at a CV, you'll see numerous trials of comparative effectiveness about colorectal cancer screening strategies, and specifically ones targeting underserved populations. In addition to running big epidemiologic studies about the impact of surveillance colonoscopy. And many people know Dr. Gupta through his service roles at the NCCN, where he leads
Recording in progress.
or chairs the panel on high risk genetic assessment for colorectal cancer. So on that, he has to make help guide us on decisions about things like universal genetic testing in colorectal cancer. But we personally have really benefited from Dr. Gupta's mentorship, and having heard him speak in a few different settings, I can really attest that he's a master communicator. Without further ado, we're really excited to hear him talk about colorectal cancer and some of the dramatic changes that we're seeing in the incidence and rise today. So with that, thank you, Dr. Gupta.
Thanks so much, Bob. It's going to be hard to follow up that introduction and deliver on the expectations, but I will try. Can you give me just one moment to set things up here? I was having a problem with my browser. One quick second. Okay, is the sound coming through okay?
Perfect.
Okay. And slides look okay too?
Looks good.
Okay, great. So I really appreciate this opportunity to talk to you all about birth cohort colon cancer, which I really think all of us should be thinking about as a generational challenge for cancer control. And I want to start with a case. I think this helps us really think about the problem. So this is a woman in her 20s. She was born in the 1990s. 2 years before I met her, she started developing bloating and a change in her bowel habit. About a year prior to her diagnosis, she developed intermittent blood and stool. About a month prior to her diagnosis, she started to develop dark blood and mucus in her stool every day. And she then underwent a diagnostic colonoscopy that showed this very large 6 centimeter mass. This was a tubulovillous adenoma with multifocal high-grade dysplasia. So this near certainly would have turned into a cancer within about a year of this exam if it had not been removed. She was very healthy. She had a BMI of 21, non-smoker, and it being San Diego, she's a surfer. And she did undergo a germline cancer risk gene evaluation that was negative. So this was not because of Lynch syndrome or another hereditary syndrome. And her questions are really similar to what we hear from other people who've experienced colon cancer. Why did I develop this tumor? And how could my tumor have been detected earlier? And I think really these are the fundamental questions that we need to set ourselves to answering if we're going to address the changing epi. So as the outline for my talk, we're going to first start by reviewing the changing epi and the birth cohort trends. I'll go over what's known about potential causes, and then I'll close by talking about some strategies for addressing the changing epidemiology. So we all know that colon cancer is a major public health problem. It's the third most incident cancer in the United States and the second leading cause of death among men and women. We're projected to have nearly 160,000 cases this year and about 55,000 deaths. The lifetime risk is about 4% for both men and women. And something that's really striking about colon cancer, it's true of many cancers, is that the incidence goes up with age. And that's shown in this graph on the right, which shows age on the age categories on the x-axis and the rate per 100,000 on the y-axis. And you can see that there's a very strong age-specific incidence trend. And we'll be looking at other data similar to this as we think about what's changing. So if we look at colon cancer trends overall, we can argue that we've largely had a success story. This graph shows time on calendar year, time on the x-axis, and cases per 100,000 on the y-axis. The blue line shows colon cancer incidence, and the green line shows mortality. And what you can see is that for all groups combined, the incidence and mortality have really dramatically improved over time. And we think this is because of implementation of screening, particularly in the early 2000s, reduction in exposure to risk factors such as tobacco smoking, and also to some extent due to better treatment. But as you can see, there's a flattening going on here in both the incidence and mortality. And this overall curve really represents an incomplete picture. And in fact, the recent annual percentage change for both incidence and mortality have not been changing. And the reason for this is because we are experiencing generational trends in colon cancer, and these are both established and emerging. So, for example, among people born 1960 and later, we're seeing increasing incidence under age 50. So this is early onset colon cancer. I think all of you have been exposed to this, even if you're not a researcher in the area, just in the lay press. But what you may not know is that there's also increasing incidence trends among middle-aged adults, 50 to 54 and even 50 to 60, and a flattening of prior decreasing incidence trends in people 55 and 60 and older. This is going along with some changes in the characteristics of colon cancer that we're seeing. We're seeing more rectal compared to colon cancer diagnoses. Many more people are presenting with distant as opposed to local stage diagnoses than previously. And the increasing incidence, at least for people under 50, appears to be affecting all racial and ethnic groups. And something else that I want to underscore in the next few minutes is really that there are cohort trends surrounding this. So the risks that we're seeing in terms of colon cancer are higher with each successive generation. And for this reason, we and others have been trying to push the idea that we should expand our discussion as we talk about the changing epi of colon cancer from just focusing on early onset to really talking about the concept of birth cohort colon cancer. So I want to just stop for a moment. I know I'm speaking to a room that probably has a bunch of epidemiologists, so correct me if I get any of this wrong, but I think it's worth thinking a little bit about what it means to have a birth cohort effect. So this is when an outcome such as incident colon cancer is determined by the year of birth or the birth cohort. And the reason these are interesting is because birth cohorts share exposures that influence outcomes. So it could be a historical event like World War II, as we think about the baby boomers. It could be social experiences, such as the introduction of social media. And there can also be socioeconomic, behavioral, and shared environmental risk factors that also occur based on year of birth or birth cohort. So how does this apply to the colon cancer trends? So this chart is something that I was lended by Dr. Caitlin Murphy, who you all may know as an epidemiologist at University of Chicago, really a thought leader in thinking about birth cohort trends in colon cancer. And what's shown in this chart is a birth year or birth cohort on the x-axis and the incident rate ratio for colon cancer on the y-axis. And the referent group here is the baby boomer, 1955 to 1959. So if you look at the silent generation, a similar incident rate ratio compared to baby boomers. But after that, we really see an increasing trend. So higher incident rate ratio for people belonging to Gen X, and even higher incident rate ratio among millennials. And what's a little scary about this is there seems to be an acceleration going on here in the later birth cohorts. We can look at these data in a different way. Again, this slide is courtesy of Dr. Murphy. Here, these are age-specific incidence data. So age categories on the x-axis and the incident rate per 100,000 is on the y-axis. And what's shown here is the age-specific incidence for people born in the 1950s in the green, 1960s in the yellow, and 1970s in the orange. And what you can observe is that there's a left shift such that the age-specific incidence curve starts to rise sooner. And in the case of the 1970s, appears to be accelerating or being steeper for people born in the 1960s and 70s compared to those in the 1950s. So this is really remarkable. I mean, to see this kind of shift in an age-specific incidence trend over such a short amount of time is really dramatic. I would say these data, as a gastroenterologist, remind me of some of the data that went towards supporting earlier age of colon cancer screening initiation for people with versus without a family history. So this is a classic article from 1990s where they show age-specific incidence data for people without a family history versus with a family history. The rise occurs faster as earlier in people with a family history. And this is the reason why we tell people with a family history to start screening 10 years earlier or by age 40. So one of the reasons to emphasize birth cohort patterns is these are really potentially an important clue to trying to help us figure out what's going on. So what we're seeing is that with successive generations, whatever the factors are that are driving the increasing incidence, we can hypothesize these to be becoming either more prevalent or more concentrated in the population. Whatever this thing is that's going on, it has to be worse for people who are being born more recently compared to those more remotely. I want to shift now and talk a little bit more about some of the data behind some of the other trends that I mentioned in the overview slide. This slide shows trends over time by anatomic subsite. And the purple line shows the trends in proximal colon cancer. The orange shows the trends for rectal cancer, and the green shows the line for distal colon cancer. And what you can see is that if we look at people who are under 50, there's a marked increase in incidence for early onset distal and rectal cancer, whereas the proximal is pretty much flat. We see an increase in middle-aged rectal and a flattening of prior decreasing incidence of proximal and distal cancer in middle-aged people. And then for people over age 65, we're starting to see a flattening, especially in the rectal cancer. And the key point here is that the causative agents that are driving the changing epi are impacting rectal cancer more than distal cancer and don't appear to be really impacting proximal cancer. So this might help us to triangulate causes as well. There are also some trends in stage distribution. So this shows the stage of cancer diagnoses over time, also broken down by age group. The black line is localized, the red regional, the blue distant, and the pink is unstaged. And what you can see here is that overall regional incidence is rising, especially in that young onset group, but also even in this 50 to 64-year-old group. The key point is that increased regional and distal cancer really suggests that we're diagnosing more people based on symptoms rather than screening. And we would expect this would have a disproportionate effect on people who are not eligible for screening under age 45, and also among people who might be eligible for screening but have not yet participated. So the consequences of being unscreened now are probably worse than they were previously. The changes are impacting who gets colon cancer by age. Again, this may seem obvious because early onset is in the news. This pie chart shows the distribution of colorectal cancer cases by age in 1992 versus 2019. What you can see here is there's a shift to a higher proportion of cases being accounted for by young people. So the 40 to 49 group in 92 was 5% of cases. Now it's nearly 9%. The group that was 50 to 59 was 11.6% in 92, and now it's 20.5%. So these are substantial shifts. And the key point here is that now the people who are getting colon cancer, there's more people at risk for more life years lost and of needing to have survivorship concerns addressed. And we're also at the point where early onset cancer is the #1 cause of cancer death under 50 in the USA. So colorectal cancer, sorry. The changes are also impacting who gets colon cancer by race and ethnicity. These are similar pie charts from 92 and 2019 showing the distribution of colon cancer cases by race and ethnicity. What you see here is a doubling of the proportion accounted for by Hispanic Latino individuals, as well as for the Alaska Native, that's shown here in purple, Alaska Native American Indian populations, and an increase also for Black people that's shown here in the mint color. And the key point here, so this is not because the changing epi is necessarily impacting uh, certain race and ethnic groups more than others. If anything, it's probably impacting non-Hispanic white people more. But the reason we're seeing this shift is because of shifts in population demographic. But the end result is that the burden of colon cancer is increasing among racial, ethnic, minoritized people due to these changes in population demographics. So the changing epi is not just affecting the United States, it's global. There's this one great study from last year that was of population-based registry data worldwide, mostly from 2013 to 2017. Here, they focused on early onset colon cancer incidence, and they found that it was increasing in 27 of the 50 countries and territories that were looked at. The rise was exclusive to early onset or faster than for increases in older adults in 20 of the 27 countries with rising incidence. And to me, the main take home from this study was that the increases in early onset were no longer limited to just high income countries. So again, whatever's driving is something that is more of a global phenomenon. I think it's also important to note that the birth cohort trends in cancer incidence extend beyond colorectal cancer for people born before versus after 1955. So this study demonstrated that we're seeing increasing incidence in people born after 1955 versus before for kidney and pancreas cancer. And then very worrisomely, we're seeing a reversal of prior decreasing incidence to now increasing incidence for breast, uterine, stomach, testicular, in addition to colorectal cancer. So it's possible that there's some shared risk factors here in the mix, and we may need to widen our lens as we're thinking about the drivers. So in summary, I hope I've shown you now that early onset colon cancer is persistently rising and that there's also a clear and worrisome birth cohort effect. Early and now middle-age colorectal cancer is increasing. The risk is multiplying with higher risk for younger generations, and the overall burden of colon cancer is increasing among younger aged individuals. These trends are global and no longer limited to high-income countries, and the increasing birth cohort trends for cancer incidence extend beyond colorectal cancer to other cancers as well. And to me, this means that the changing epidemiology is really a generational challenge for us and a huge opportunity for research and development. I want to shift now and talk a little bit about potential causes. We and others have conceptualized thinking about the potential causes. There's really two big buckets of contributors. We can think about genetics, and we know that the genetics really are not, population genetics are not really changing, so this is unlikely to be the main driver. But we do know that our genetics interact with our exposomes, or the sum total of exposures. These exposures could be early life exposures, such as the status of the mother in terms of their metabolic status or medication exposures. It could be diet and lifestyle factors, environmental factors, metabolic disorders, and all these exposures could also influence our microbiome and subsequent metabolites. So the thought is that the exposome interacts with our genetics to drive somatic alterations, and this is really what is leading to these changes in colorectal cancer. And we really need to focus our attention on trying to figure out which factor or factors within the exposome are driving the trends. So what are some of the causal clues? So we would think that the suspect should have one or more of the following characteristics. It should be something that is becoming more prevalent or concentrated with successive generations. We would expect that it's something that has a global presence. We would want it to be more closely associated with rectal or distal cancer. And we might expect that whatever the factor is, it should be present in early life. This one is not a definite one, but we would expect that if we're seeing early onset cancer trends, that an early life exposure could be something that could be a big driver. So what's known? And the reality is that despite about 10 or 15 years of research on this, we really don't know much. most of what's out there has really focused on just early onset cancer and has not really taken this birth cohort perspective. And the main findings I'll summarize in this slide, and what the take home is that the risk factors for early onset cancer include the usual suspects that we already knew were associated with colorectal cancer in general, as well as some unique exposures. So, for example, there are metabolic factors. So, obesity and hyperlipidemia have been associated with early onset colon cancer. I would say the data on diabetes are more mixed. We've got exposure. So, alcohol and smoking have been associated with early onset cancer. I think alcohol is probably the most consistent association that we're observing as far as early onset. We have some interesting data from the Nurses' Health Study that suggests that exposure to sugar-sweetened beverages, as well as sedentary behavior as measured by more TV watching, is associated with increased risk. And then we do have some data on in utero exposures that suggest that exposure to long-acting sulfonamides, maternal obesity, and the no longer used anti-nausea agent bendectin are associated with risk for early onset colon cancer. Have been some studies of diet and colon cancer precursors that to me are intriguing. So from the Nurses' Health Study 2, they have reported that a Western diet is associated with a 1.7-fold increased risk for high-risk adenoma and distal or rectal adenoma under age 50. They also did an analysis that suggested that ultra-processed food intake is associated with 1.5-fold increased risk for any adenoma under age 50, including increased risk for distal or rectal adenoma. This to me is interesting because ultra-processed food intake in the US has increased from accounting for about 54% of energy intake in 2001 to about 57% in 2018. So there could be some plausibility here. In terms of environment, this is a wasteland, really. There's no published early onset or birth cohort specific risk studies. I have found one preprint that's been out there now for 2 years that found an association between methylation-based tumor signatures of exposure to the herbicide picloram and early onset cancer. There's been prior work that is not specific to early onset or birth cohort colon cancer that has found increased colon cancer risk associations for certain insecticides, air pollution, some drinking water disinfection byproducts, and there's limited to no research on other agents that might be of concern, such as PFAS, so per and polyfluoral alkyl substances and microplastics. So one of the reasons that I'm really emphasizing this is this is a big opportunity for us to look into it. And I think it's worth noting, again, this slide is from Dr. Murphy at University of Chicago. It's worth noting that there's been a big change in our exposure to some of these environmental pollutants. So this graph shows birth cohort or a birth year on the x-axis. The green line shows the incident rate ratio for colon cancer versus baby boomers and the rise that we've already talked about. And what the blue line shows is the increase in synthetic organic chemical production in billions of kilograms over time. And you can see it's gone really, really way up. Some of these examples include PFAS substances. And so this is not to say that these are necessarily the drivers, but the extreme change in the exposure to these substances certainly warrants further investigation. We can't have no studies on this at this point, and we have to be looking into it. In terms of the microbiome, I have a colleague here, Ludmila Alexandrov at UCSD, who led this really important study last year. They looked at tumor mutational signatures in colon cancer specimens from 800 individuals with microsatellite stable colon cancer across 11 countries. And what they found was that signatures associated with exposure to colibactin, which is a toxin produced by certain bacteria, such as certain types of E. coli, was more common for people who had colon cancers diagnosed under age 50. So that's shown in the graph at the right, where you've got age of onset on the y-axis, and you can see that people who are colibactin positive tended to be younger than people who are colibactin negative. And they in their report, they did some experiments that suggested that Colibactin-associated mutagenesis appeared to be an early event in the carcinogenic cascade. And I think some of the natural questions from this study are the findings replicable? Does the prevalence vary by birth year, not just by age of diagnosis? And what's really driving the early life exposures to bacteria that produce colibactin? So if you ask Ludmil, he'll say, he's not so sure that it's necessarily early childhood exposure to antibiotics, but certainly that needs to be looked into. In terms of limitations of prior research, I want to talk about the focus on age versus birth cohort as a limitation, the study designs, and our focus on low-hanging fruit. So in terms of the focus on age versus birth cohort, when we focus on looking only at people who are younger than 50 or comparing people younger than 50 at colon cancer diagnosis versus older, this groups people from heterogeneous birth cohorts. And that might lead to heterogeneous results. That might actually reduce our ability to find important associations. It also represents a missed opportunity to leverage the power of birth cohorts. So we could compare people with versus without cancer within both birth cohorts. So we could compare exposures for people born in the 1960s and 70s versus 1950s. And we could, from a practical standpoint, we could leverage the increased sample size that comes from including middle-aged cases. So although early onset cancer is increasing, the absolute number of cases is still limited. We have reduced efficiency. And we have more cases from people born in the 1960s who are age 50 to 59 versus under age 50. If we start to take a birth cohort perspective, I think it's valid to really start including those patients in our epi studies as we're trying to find causes. In terms of study design, so we all know the limitations of case control and retrospective cohort studies. Exposure ascertainment is difficult, and there's potential for recall bias. And of course, it's challenging to infer causality. Another challenge that Dr. Murphy will emphasize all the time is this problem of one-at-a-time hypothesis testing. And we don't have time to be doing one-at-a-time hypothesis testing. We really need large-scale exposome-wide association studies to move the needle in the same way that GWAS studies really move the needle for cancer treatment. We know that prospective cohort studies are expensive and they take too long from what our survivors are telling us. And my observation is that I think there's been really limited leveraging of translational research. So one question is, what could it look like if we looked for epidemiologic associations? We were able to do translational studies with human samples to try and confirm some of these associations. And we also did mechanistic studies with cells, animals, and other models like organoid models to try to see if the epidemiologic associations and those exposures actually drive any real carcinogenic changes. Could this help us to shift the way that we think about inferring causality or potential causality? In terms of the focus on low-hanging fruit, there have been a lot of studies using existing data sets, electronic health records, looking at demographic characteristics and comorbidities. I really don't think we need to do many more of these. I don't think we're going to find anything new. Another problem is that we aggregate all locations of colorectal cancer, and I've shown you that the trends really favor disproportionate increases in distal and rectal cancers. So if we are going to do a research with existing data, it would be better for us to pool and try and look at rectal separately and maybe distal separately. And in contrast, there's been really limited study of potential birth cohort related factors like diet, environmental exposures, and factors that alter the microbiome. This is what I really think we need to lean into. So what are our options for optimizing research into potential causes? So one recommendation would be for us to try to group patients and samples by birth cohort rather than only by age. I think we need to do translational studies that combine epidemiology and lab science. So careful case control or cohort sampling, really leveraging the novel technology, so novel exposure outcome measurement strategies. So we've got so many omic technologies, but especially those that focus on the exposome, such as those that are mass spectroscopy based, and the assessment of risk factors or profiles of risk factors. We can also look at mutational signatures of risk factors within tumors. So one observation that many of you may be aware of is when you look at the atlas of various tumor signatures and the potential environmental exposures, there's some mutational signatures that appear over and over again where we know the association. We know that there's a tobacco signature association or a UV light signature association. But there's many other signatures which appear persistently both within cancer types and across cancer types for which we don't know the cause. And so it would be really interesting for us to try to figure out what the drivers behind those signatures are. I think we also need to use multiple strategies to infer associations. So looking at intermediate indicators of risk, such as advanced polyps, could be useful, and also correlating epi findings with organoid and other models that might help us to accelerate discovery, help us to refine hypotheses. I think while we're thinking about all the potential causes and trying to do the research that is going to take time to figure out the causes, it's important for us to remember that we need to also be working on interventions to mitigate risk. When I think about this, I'm reminded of my mentor, one of my mentors, Dennis Anand, and he described to me, he often told this story of being at a meeting where they were debating whether or not to reduce the screening age for colon cancer. And the mother of a person who had died of colon cancer came to the microphone, and she basically said, people are dying out there. And the point that he took away from that is that, hey, while you all are talking about all this stuff, like you need to be doing something now to be helping people who are at risk or who are experiencing this. And for me, as I think about this, I really think about three opportunities. One is to optimize on-time screening. The other is to make sure we're doing well with early high-risk screening, and then to be doing some innovation around timely detection in people who have symptoms. So in terms of on-time screening, I think this problem is probably obvious to many of you. This graph shows the proportion of the US population who's estimated to be up to date with screening, who's age eligible, so 45 and older. It's 67% overall. It's been pretty flat, right, over many years now. So we have work to do here. It's lower in people who are newly eligible for screening. Okay, that's not unexpected. This still is a lower risk group, but still here we could do better. The big opportunity group to me is the middle age group, especially that 50 to 55, 50 to 60 group, where we're still under 70%. And that's because people who are not up to date today are at higher colon cancer risk than they were 20 years ago. That's the big difference. And there's an urgent need to implement well-established evidence-based interventions. So we know systematic reminders and clinician recommendations work. Offering test choice has been shown to be important. So offer colonoscopy and at least one non-invasive test, such as a stool blood test. And then population level interventions like mailed outreach offering FIT, that's been shown time and time again to work. We need to make sure these are in place in every health setting. We might even consider earlier initiation of screening in Taiwan. They did find that starting FIT from age 40 reduce incidence and mortality. I don't know that our healthcare system can bear this right now, but it's something we may need to think about, especially as that age-specific incidence curve keeps on moving to the left. In terms of high-risk screening, so I already told you we don't think genetics is driving what's going on in terms of early onset or the birth cohort trends, but this is still a missed opportunity. We know that family history, such as having a first-degree relative, is well established as criteria for early age of initiation. But if you look at people who are diagnosed with colon cancer at an early age and when they should have started screening based on their age, the studies have shown that about 82% of them could have been diagnosed earlier, and maybe up to 70% had their cancer even prevented if they had had the guideline followed for when they should have had their colonoscopy. The polygenic and environmental risk scores, there's been a lot of research on this. It's promising. It's been shown that people with or without a family history, these scores can assign optimal screening initiation ages. The problem here is that the area under the curve of these is still 0.63, and the implementation, so we still need to do a little bit better. It's not quite good enough for I think, for assigning screening ages. And then implementation remains a challenge. It's hard for me to think of an example where we're using polygenic risk scores in the clinic to do something. So what are the needs here? I think we need to optimize use of family history-based guidelines. We need implementation strategies for polygenic risk scores and other risk scores. How do we get these into the clinic? And then could we combine novel biomarkers, maybe something that's somatically measured or real-time measured, with the polygenic risk score or the environmental risk score to help really figure out who might benefit from earlier initiation age? In terms of timely diagnosis, this is a frustrating problem. If you talk to survivors, this is often the number one complaint. Why did it take so long to get my cancer diagnosed? And this is despite the fact that the common red flag signs and symptoms associated with colon cancer have been well established. We know that people with hematochezia, abdominal pain, altered bowel habits, weight loss are at increased risk. The delays in diagnosis are common. So in this study led by my colleague Josh Dem here at UCSD, this was a systematic review and meta-analysis. He showed that the mean delay was 6 months and the median delay 4 months, but really wide range variation if you look at the standard deviation and interquartile range. And the problem here is that, of course, most, for example, young people with hematochezia do not have colon cancer. So we need a strategy for this needle in a haystack problem to pick out the people with the symptom who actually have colon cancer. And the symptoms are highly prevalent, but if you look at any given symptom, the positive predictive value is low. So it turns out there's already a solution for this, and it's really been tested and it's in practice in the United Kingdom. And this is the concept of doing symptomatic fecal immunochemical testing. So some of you may know that there's something known as a quantitative FIT. So the typical stool blood test or FIT we do in the US gets reported out as a positive negative result. But it turns out that many of the FITs that we're using in our clinic, they're actually a quantitative FIT, and it measures the absolute hemoglobin concentration in the fecal sample. So what that means is you could actually set the cutoff lower. And it's been shown that using a lower abnormal test cutoff than for screening improves the sensitivity. So you get 95% sensitivity at a 4 microgram per feces threshold, as opposed to the standard 20 microgram threshold that we use to call a positive test for a screening test. And this has been shown in a systematic review that include over 13,000 subjects. And I mentioned the UK guidelines currently recommend symptomatic FIT to help triage patients for people who have signs and symptoms such as a change in bowel habit, iron deficiency anemia, or who are age under 50 with unexplained abdominal pain or weight loss. So the idea here is you do the FIT. If it's positive, do not pass go. You go to colonoscopy. If it's negative, you're less likely to have colon cancer. You can try some alternative treatments and diagnoses. And then if the patient remains persistently symptomatic, then you could send them for a colonoscopy. But despite there being all this data in the UK and it being implemented in practice there, we have no studies in the United States of looking at this strategy. So I want to close. I hope you all will indulge me if I can present a proposed approach. So this is a PO1 proposal we have. I worked on it with my colleagues now for 2.5 years. We met every 2 weeks. It's going to get reviewed at the end of this month, so we'll find out what happens. We submitted it in September. And I wanted to just present to you our project ideas. So the first project is exposome and underlying mechanisms linked to birth cohort colon cancer. So the goal here is to identify the exposome metabolome genome networks enriched in birth cohort colon cancer using deep phenotyping. So here the question is, what environmental and other factors are linked with colon cancer? The second project is organoid models for exposome metabolome genome networks enriched in birth cohort colon cancer. So here we want to define the cellular and genomic responses to environmental exposures that are relevant to birth cohort colon cancer using organoid models. And the questions here are, of factors linked with colon cancer, which are the most likely to cause colon cancer, and what are the ways in which these factors cause colon cancer? And then the third project we're titling Actionable Strategies for Birth Cohort Cancer Risk. And here we want to evaluate non-invasive diagnostic strategies such as FIT and blood-based cell-free DNA tests for ruling out colon cancer in symptomatic patients. We also want to get stakeholder input on the strategies for addressing diagnosis and risk. So the main questions here are, can a stool or a blood test be used to rule out colon cancer in people who have symptoms? And what do stakeholders advise for the research and next steps for policy and practice? So I'll give you a little bit more detail on each of these projects. The project one is led by Dr. Caitlin Murphy and Dr. Jin Hu. Jin Hu's at Emory. The idea here is we would collect blood samples from colon cancer cases and controls born 1960 and later. We would use mass spec and other technologies to identify some of the drivers of birth cohort colon cancer. And then in terms of our data extraction, we would conduct targeted analyses of things that we're already interested in, like PFAS, as well as some non-targeted analyses to try to identify things we may not be thinking about. In project two with the organoid models, this will be led by Dr. Sonia Kupfer, who's a gastroenterologist and translational scientist at University of Chicago. So the idea here would be to expose the organoids to environmental and other prioritized exposures that may drive colon cancer risk, including some that we discover as part of the first project, and then to assess the cellular alterations and genomic responses. And then in the third project, this one I'm leading with Dr. Fola May, who's at UCLA. She's a gastroenterologist there. So here we would identify a symptomatic group presenting to primary care with new rectal bleeding, change in bowel habit, constipation, anemia, abdominal pain. They would give us a FIT sample, a blood sample for a cell-free DNA test, and then everyone would undergo a reference colonoscopy blinded to the FIT and cell-free DNA results. So basically, we would establish or confirm the test characteristics of using a low threshold FIT for ruling out colon cancer. So what would be the anticipated outcomes? We hope to establish a novel model for discovering drivers, to discover novel exposome metabolome genome networks, including environmental factors that are contributing to colon cancer. We think we can demonstrate the performance of a novel symptomatic FIT strategy for detection, and then be in a position to disseminate actionable strategies for addressing timely diagnosis and risk. So in summary, I've shown you that the epidemiology of colon cancer is changing. There's increasing early and middle age onset with clear birth cohort effects. This is a global problem, and I think it's really a generational challenge for all of us to address. To address the challenge, I think we have to employ innovative epi and translational research. We need novel strategies for risk assessment and triage. And then, of course, we have to optimize screening participation from a public health standpoint. I want to thank you all for your attention, acknowledge grant support. I do want to call out Doctors May, Kupfer, Murphy, and Hu. I mentioned that we've been meeting every 2 weeks for 2 years trying to develop these ideas, and much of my thinking and my knowledge about this has been really as a result of those really regular conversations. As we were talking about timely diagnosis, so Josh Dem, who is a postdoc with me and now is an independent faculty member at UCSD, really has led the generation of these ideas. And then I did get some help from a medical student with some of those slides about the PO1. So thank you very much.
That was a really fantastic talk, Samir, and I approve your grant, so I hope it gets funded.
We got to get you on the review committee. I don't know. I'm terrified.
I have tons of questions, but I'll open up for others.
So, Bob, I've raised my hand. Can I ask?
Yeah.
All right. Samir, first of all, I give you a 10
Oh,
on
okay.
your program project grant. I will be thinking of it and hope that it gets reviewed favorably. It is the question right now that is needing an answer. So congratulations for putting it together. My question, I'll start with the PO1. I'm wondering, you're taking a birth cohort approach, which is good, and you will have a smattering of people who will be not typically being diagnosed with less than 50 years of age, at 50 years of age. So you'll have a comparison group, so to speak, of those who are diagnosed at an older age. But I was curious to know why you hadn't taken people who were truly in the lowest risk group, as in the 65 plus age group, to have some extremes of examples for comparison.
Yeah. Um, so I'd answer that in a couple of ways. So if we're taking people 1960 and later, we will actually start to get some people even as old as 60 in
Or
our
you'll
group by
get
the time
them
we
as
start enrolling.
64 years of
Yeah.
age and 65 years
So
of age. I'm acutely aware of
yeah.
that.
So we
So,
will get some of that, but
mhm.
um, I I think it's a valid critique. I think we wanted to lean into the birth cohort issue. I I feel like, and in our conversations, that we're going to learn less by comparing younger cases to older cases, as much as comparing younger people who have it versus those who don't. And that's maybe my bias. I kind of I'm not sure that older people with colon cancer are the best comparison group for understanding what's different in younger people. That's one issue, and the second is the budget issue. You come up against that, especially with these translational studies, really really quickly. So that also was part of the rationale.
Fair enough. I'll request Bob, can I ask another question, please? Please.
And I think he did such a good job summarizing everything that's impacting the subject. I'd be curious to hear, you're connected with a lot of circles about where is the pressure for funding on this topic? Are people more pressing towards the exposures, more towards the translational, or is it just like the diagram where there's equal focus?
Yeah.
I'd just be curious from all the big parties that you hear from.
I I don't know. I mean, I think what I can tell you is just the small circle of survivors that I interact with. They're focused on those two questions I led with. Why? And and why did it take so long to get diagnosed? I feel like that's what I hear over and over again in the stories. But in terms of how funders are thinking about it, I don't feel like I have a good sense. I have to say, one of the things I have not made enough time to do is to go to all of the different early onset cancer focused conferences that are out there. There's a lot of interest and I have to say I haven't been able to go to all of them. But then I hear from, Caitlin Murphy and Fulla May, they go to these and I feel like what they've taken away, at least from conversations with NIH, is, yeah, they're interested, but especially right now, right? So many hoops beyond that in terms of beyond there being interest, actually getting a reasonable score and then getting the money is a whole nother issue.
So, Bob, to answer your question, actually, on the National Cancer Advisory Board, early onset cancer is near the top in terms of priority. So, and especially looking to see the exposome, it's very much a question that they're asking. So, where the PO1 is going is right on the money.
Oh.
It is.
And one last question about the PON. I was just thinking about Freenome when I saw that blood-based samples that you'd be collecting too. Is that part of that last hypothesis in the project?
That one we got a letter of support from Guardant, which, as you know, makes a competitor blood-based cell-free DNA test that's FDA approved for screening. So they gave us a letter of support that they would pay for the test and the mobile blood draws. So we'll see what gets followed through on, but that was the promise or how we went about that.
Yeah, Wendy, you're muted, Wendy.
Thank you for that fantastic talk. My question is about HPV. So given that the association with anal cancer and the increased incidence of HPV over the last few decades. I'm just wondering if that's being explored in terms of especially the rectal cancer, the etiology.
Yeah, I'm glad you asked about this. I have not done a lit search on this anytime recently. I feel like the last time I did it, I did not find anything that came up about this. But certainly worth looking at. And I mean, this is, I would imagine, I think again, I should do a lit search around this, but I imagine since we can look for evidence of HPV in these tumors that someone has done that. But are you aware of anyone who's looked at that for rectal adenocarcinoma?
I am not, but yeah, I would
Okay.
be interested in knowing if
Yeah.
that's, yes.
Samir, you know, way back when we were doing epidemiology growing up, the primary reason risk factor for colorectal cancer was eating hot dogs and processed meats, right? So, with that in mind, has there been any? I know the global studies are showing that the risk is increasing, but I think the diets are changing as well. And you go to India, everybody's eating hot dogs now. But the question becomes, if we look at, has anybody looked at the migrant story? People who have recently, the first generation migrants whose diets haven't become westernized, to see if that same pattern remains, or does it evolve with the second generation migrants?
Um, this is a great question. I'm not aware of anything. I can think of at least one way to look at this. So I think the California Cancer Registry includes data on the immigration status, and I would imagine they might have enough sample at this point for someone to take a look at that. So we could work with Scarlett Gomez at UCSF and talk if someone was interested in championing that. I think it's
This would be a
probably
good
feasible.
postdoc project. Yeah.
Yeah, I think that sounds like a feasible project.
Yeah. Other questions? Well, the field is so wide open, right? You're taking colorectal cancer on, but then there's pancreas and there's stomach and there's testes and there's breast, and they all are begging to be
Uterine.
studied. And
Yes. Yeah.
uterine, yes,
Yes. Yeah.
yes. So something is changing
Yes.
drastically in the environment too.
One thing I wonder about, I don't know if you all have thoughts about this, is whether it would be useful to also pool across cancer types in some of the studies.
Mhm.
In some of the, here I'm thinking about exposome studies. And, is the right way that you do it within disease type and you see, okay, it's smoking here and it's smoking here and it's smoking here, and then you put it all together? Or could there be some value in pooling, in terms of just the ability to detect things that might be a little harder to detect? Could there be some value in pooling um, across cancer types? I'm not sure, but I'm wondering about that actively.
Your next PO1, Samir.
Okay, let's try and get one first.
You will get this one for sure. We're telling you that. Any other questions? You need to develop a risk prediction model, Samir, with
Um,
all these pieces of data to identify who to screen at what age.
yeah. No, it's out. I think the polygenic risk scores, I think they've been pretty in terms of bringing in lifestyle factor, the environmental risk scores. You may have read some of these papers. They take into account smoking and diet, and I feel like they're pretty comprehensive. Maybe someone could argue that we need more contemporary patients to contribute to those risk scores to see if anything is updated. But my takeaway is they're good, but again, we need one or two more things that something that's more of a real-time biologic measure of risk. And if we could combine that with the PRS, maybe that could be a way of of making it
Absolutely. Yeah.
making a better assessment of screening age because
Mhm.
on the flip side, we've got pretty good tests,
Mhm.
and not everyone has to have a colonoscopy.
Mhm.
The specificity of the non-invasive test is better at younger
Mhm.
ages.
Mhm.
So, I mean, it's expensive, so I don't want to ignore that, but
Mhm.
there's it's feasible to consider starting screening earlier in select groups if we had a good risk stratification approach.
And James Church suggested we just remove the sigmoid colon from every person shortly after birth. A lot of this
Okay.
issue, constipation, volvulus.
Prophylactic colectomy. Okay.
You're doing without an ostomy, though. We
Yeah.
don't want your ostomy wrap up.
We'll save
Oh
that
my
one.
goodness. Yeah. Well, thank you so very much, Samir.